This is a sketch by Leonardo da Vinci, and this is a plasticized human body prepared by Professor Higgins of Germany, who now plasticization is a process. Please just look into the Googles and you search a site, you will get like formaldehyde. It's formaldehyde is injected, then the body is put in acetone chamber and completely dried, and plastic is injected into the dead body. Like formalin is injected into the dead body. After that, that formalin is taken out. The water, it makes 100%. There is no water is there. That is the acetone is chambered. They put the dead body, and then they inject plastic. So it will stay for millions of years. Okay. Another thing is that you can carry the dead body in the suitcase. Even the brain is such a pliable structure. It just is so delicate. But it's once plasticized, you can play throw ball with the human brain. Now, this bit of introduction. Now we'll go. Now, shape of the uterus, a full question can come, or not, I mean, 10 marks question can come. Describe the uterus and describe the supports of the uterus. Supports of the uterus is the question very commonly asked, and also in Viva, you will ask the supports of the uterus, the position, the bladder, in between the bladder and the rectum, within the broad ligament, lower end. The short question comes on angle of anteflexion and anteversion. The uterovesical pouch, intestinal surface related to the sigmoid colon and coils of the small intestine covered with peritoneum. Lateral margins receive the uterine tubes. This is important. Receive the uterine tubes, uterine vessels by the side and related to broad ligament, mesometrium, and ligament of the ovary. Cavity of the body is triangular in Cardinal section, but merely as a in the sagittal section. If we have a specimen of the uterus in the dissection hall, you can see I have cut through the thing. You can see the cleft, the description, and when you go for practicals, please see the uterus in detail and its relation in the that's a section. Sagittal section of the human body, on the pelvis, prepared by Supports. Now, you can see the relation. And when you go to the hall, your demonstration room or dissection period, you please see these organs today and or your respective class. Now, parts and relation. Isthmus, constricted part of the uterus 1 cm in the length and cavity called internal os. Cervix extends downwards and backwards from isthmus to pierce the anterior wall of the vagina, divided into supravaginal and vaginal parts. Supravaginal part anteriorly bladder, posteriorly coils of small intestine. Laterally uterine artery and ureter embedded in the parametrium. Vaginal part protrudes into the vagina, forms vaginal fornix. The cavity of the cervix, the cervical canal, is spindle shaped and communicates with cavity of the body through internal os and with the vagina through the external os. Now, peritoneum, from middle 1/3 of the rectum, the peritoneum reflected onto the posterior surface of the part of the vagina, and recto-uterine pouch, a pouch of Douglas. This can be a short note of 4 marks. Okay, continues over intestinal surface of the uterus body and passes down fundus. Continues down over the vesical surface of the body at the level of the fornix anterior of the vagina and peritoneum reflected onto the posterior surface of the bladder. Now, blood supply of the uterus is the uterine artery, branch of the internal iliac artery. Now, the ovarian artery, partly branch of the aorta and rising from L1 level. Venous plexus of the uterus. Venous plexus drains through the uterine, ovarian and vaginal veins into the internal iliac vein. Lymphatic drainage of the uterus. Fundus into the para-aortic nodes, body and cervix into the external iliac nodes. Note a few lymph vessels also drain into the superficial inguinal node. Now, the lymphatic drainage, if you see in imaging, your USG or your CT scan, MRI, whatever it is, if a patient of cervical cancer comes to you, you do a speculum examination, you do a vaginal examination, and very gently, delicately, then you get a very foul smell. If there is a CA cervix, you will get a very bad smell. And blood stained white discharge, you just see your ductal speculum. You just open like this, and you can visualize the condition of the cervix. Now, nerve supply, uterovaginal portions of the inferior hypogastric plexus, sympathetic supply from T12 and L1, parasympathetic supply from S to S4. Clinical notes, uterine examination, bimanual palpation, prolapse of uterus. You do the vaginal examination. And your right hand, if you are a left-handed person, then you put this thing and palpate. After, ask the patient to evacuate the bladder, and then you can do the bimanual palpation. Now, normal position, support uterus. This is a very important your theory question. And also, in practical, they can ask you. The normal position of the uterus, anteverted, extends forward and upwards from the upper end of the vagina at approximate right angle. Anteflex, body bent downwards at its junction with the isthmus. This position is generally maintained by muscles, fibromuscular structures, facial condensation, ligaments, and possibly peritoneal folds. See, this is the picture that if you have a question, and then you please draw this anteversion and anteflexion, angle of anteflexion, angle of anteversion, the position of anteversion and position of is the angle of the 90 degrees, angle of anteversion, position of anteversion is the anteflexion, 170 degrees, and position of that retroverted. Okay. Now, important supports. This is very important. Levator ani muscles, anterior fibers, pubovaginalis from a sling support the vagina, indirectly support the uterus, and fibers are inserted into the perineal body. Note, if the levator ani is torn during childbirth, supports of the vagina is lost and it tends to sink into the vestibule along with the uterus. This is prolapse. Now, what is the prolapse of uterus? It can be a different way. They don't ask you anteversion, anteflexion, all the supports. Now, what is your prolapse of uterus? Now, the perineal body situated between the vagina and the rectum and stabilized by numerous muscles. Example, superficial transverse perineal and external anal sphincter. Acts as anchor for levator ani and maintains integrity of the pelvic floor. Urogenital diaphragm. Some fibers are attached to the vagina and help support both vagina and the uterus. Important supports. There are 4 ligaments. These are condensation of the pelvic fascia on upper surface of levator ani muscles attached to the cervix and vagina support uterus and keep cervix in proper position. Now see this in yellow, this yellow, highlighted with yellow color, the transverse cervical ligament, cardinal ligament, connect lateral aspect of the cervix and upper vagina to the lateral pelvic wall. Pubocervical ligament, the pubis, symphysis pubis and the cervix, it has a sling, and the name itself, speaks. The pubocervical ligament connects cervix to posterior surface of pubis. Sacrocervical ligament connects cervix in the upper end of the vagina to the lower end of the sacrum, forms two ridges, one on either side of the recto-uterine pouch, and helps maintain uterine access. Now, the cervical ligament maintains the uterine access. Round ligament of the uterus, remnant of half of the gubernaculum, to connect lateral angle of the uterus to the labia majora via the inguinal canal. Now, your this illustration of the picture in all your textbooks, whatever you are reading, you will get it. But you first draw at least these 4 or 5 when you get the supports of the uterus and this question. Just keep cool, draw the figures first and label them. At least a major portion of the answer is ready. Now you go on putting, you number the illustration, the figures, 1, 2, 3, 4, 5. Then you just figure 1. These are the. This is the easy way of learning and also representing in your final examination sheet. So you please, because you cannot go volumes of, you have so many things to read, so many things to study, but if you remember, you draw this picture, at least the examiner will come and give you marks. If it is a 10 marks question, you are sure to get, if it is correct, with little bit of text, write little bit of text, but you illustrate, and this is the easiest way to get score marks. Okay, now see, this is the sacrum, this is the uterosacral uterus, sacrum to uterus, cervix, here, transverse cervical ligament, and the pubocervical ligament, this is the urinary bladder, this is the rectum. Now, this is the symphysis pubis. Tear of the peritoneum. Tear of the perineum may cause prolapse of the uterus. Also, due to hard labor or weaknesses in any of the supports. Here, this is a picture, vagina, the uterus cut open. You can see the endometrial cavity, this is the ovaries, this is the myometrium. Okay. Now, this is the picture. You can see this. We have a specimen, very good specimen in the dissection hall. Please look into it because that will be placed. That will be placed. And it's a beautiful specimen. This is a laparoscopic photograph of the pelvic cavity with its uterus, ovaries, round ligament. How it looks, rectum, uterine tube, broad ligament. Now you can see this is the axis of the uterine body, axis of the vagina, axis of the cervix, angle of anteflexion, angle of anteversion. This is again a laparoscopic picture. Catheter, this is the balloon, is the catheter. Because any operation on the uterus, any operation for prolapse, Foley's catheter is put into the bladder, to the urethra. the picture of the. Now, this is an illustration from Grant's anatomy. Grant's anatomy. Now, see, simplified. This is simplified. Fundus, body, cervix, round ligament of the uterus, inguinal canal, and it settles down in the labia. Again, a picture from above in the pelvis. See the vascular supply, the anastomosis of the ovarian vessels and the uterine vessels. This is the ovaries and tube, broad ligament, the vagina, fundus of the uterus. See the importance of the ureter going into the ureter passing and the uterine vessels. So during any pelvic surgery of the uterus, you have to be very careful of the relation of the uterine artery and the vein. See, this is again the supports. You can see this picture. Now, the normal uterus, you can see the uterine cavity, the fundus of the uterus, uterine tubes, ovary, body of the uterus, cervix, external os, vagina. Now, this double uterus and double vagina, uterus didelphys, Now, this is the double vagina, this is the double uterus, with single vagina. This is common. You can find during hysterosalpingography or very 4D image of the ultrasonography. Now, bicornuate uterus, See, there's a depression, and this is the one cavity, this is one cavity. This is a single passage in the cervix, the single vagina. Now, bicornuate uterus with rudimentary horn. See, is a rudimentary horn. This is the bicornuate uterus. Now, septate uterus, there is a septum. Unicornuate uterus, single cornu, single cavity. Now you can see the blood supply of the ovary. The laparoscopic view of the pelvis. This is a section of the uterus shown on the left. This is endometrial, microscopic. There is MRI image. A location of uterine fallopian tube, upper free border of broad ligament, mesosalpinx. Extent of the uterine tube 10 centimeters long, runs laterally from uterus to the uterine tube. Infundibulum, lateral expanded of the abdominal ostium is opening, surrounding by finger-like fimbriae. One fimbriae equal to ovarian fimbriae, attached to the tubal pole of the ovary. Inner surface lined by ciliated columnar epithelium. Ampulla, medial continuation of the infundibulum, thin-walled and dilated, follows the tortuous course, arching over the ovary. Isthmus, constricted part of the medial to the ampulla, has thicker walls than ampulla. Intramural lies within the uterine wall, opens into the uterus of superior angle of the uterine cavity by a narrow uterine ostium. blood supply of the fallopian tube. These can be all short nodes of fallopian tube. Medial is 2/3 of the uterine artery, branch of the internal iliac, lateral 1/3 ovarian artery from abdominal aorta. Now, venous drainage of the uterine tube is the pampaniform plexus of the ovary and uterine veins. Lymphatic drainage moves drain into the lateral aortic and pre-aortic nodes, some around the isthmus, follows round ligament of the uterus into superficial inguinal nodes. Nerve supply, sympathetic T10L1 by inferior hypogastric plexus, parasympathetic mainly from pelvic splanchnic nerve S2, S4 by inferior hypogastric plexus. Clinical note, tubal pregnancy, this is important. Tubal pregnancy, common ectopic pregnancy, sterility caused by blockage of the tube due to inflammation, female sterilization by tubectomy, ligated and excised. Now, so ovary can be a small, in the MCQ it can come one or two this thing, how the thing, or just 2 marks short note. Now, position and orientation, it is located in the ovarian fossa on lateral wall of the pelvis, behind the broad ligament attached to the back of the broad ligament by mesoovarium. In nulliparous women, its long axis is vertical. In multiparous women, upper pole laterally and lower pole medial. Parts of the ovary, it has lateral medial surface, upper tubal and lower uterine poles, anterior mesoovarian and posterior free borders. Position, relation of the ovary, this is important. Relations of the ovary is important. Now, anteriorly obturated umbilical artery, posteriorly ureter, internal iliac artery, the obturator nerve crosses floor of ovarian fossa. Posterolaterally, fibulae of the infundibulum and fallopian tube. Fixation of the ovary, suspensory ligament, round ligament of ovary and mesoovarium. Now, if you don't find time, you don't go into the details of this. You just use suspensory ligament, round ligament and mesoovarium. At least you can convey that you know the answers, the fixation of the ovary. Now, blood supply of ovary, ovarian artery, branch of the aorta at level 1, descends in suspensory ligament to broad ligament, sends branches to ovary and uterine tube, and associated with the uterine artery. Venous drainage of the ovary, pampaniform plexus to the ovarian vein, right side into the inferior vena cava and left side into the left renal vein. This is a common question that is asked. The right and left ovary is having the right side into the inferior vena cava. The left side is the left renal vein. Sometimes the kidney specimen that might have a left ovarian vein dangling with the vena cava or the renal vein. Now, ovarian plexus derived from renal, aortic and hypogastric plexus. Accompanying ovarian artery contains sympathetic nerve T10-11, parasympathetic nerve S2, 3, 4. Thus, pain is referred to the inguinal and valval regions. Now, if there is a twisted ovarian cyst, you will have low abdominal pain, pelvic pain, plus it can be referred to the inguinal and valval regions. A twisted ovarian cyst. Now, lymphatic drainage of the ovary, pre-aortic nodes and para-aortic nodes. Clinical note, before puberty, ovary is smooth and grayish pink. After puberty, it is puckered and turns grey. When old, it may shrivel, ovarian cyst, ovarian carcinomas, prolapse of the ovaries into the recto-uterine pouch. This is again a laparoscopic picture. See the ovary? Yeah. this is the fallopian tube. This is the round ligament. This is the fundus of the uterus. This is a histosalpingography. Now, clinical manifestation of uterus, ovary, fallopian tubes. The prolapse uterus. It's a total complete prolapse of the cervix. See, this is the mucosa. The Follis catheter. This lady was treated by me by surgery. It is from my archives. Now this is again clitoris, bladder and cervix. See the polyp. It's a big polyp dangling. Now this what I did is that I first to give a relief, I did a cervical polypectomy and then I raised the bladder, did the support to get fixed up. Now, this is a huge uterine fibroid. It is in my OT. I performed this operation. Now, this is a huge ovarian cyst. Huge ovarian cyst. This is fibroid ovarian cyst. See, in those days, we had open ether anesthesia. You put a mask and then you put ether. But nowadays you are having spinal anesthesia. Plus your gas oxygen apparatus is used, nitrous, oxygen. These are through intubation. Tracheal intubation, the anesthetist presses the bladder and you can operate. But in my days, this is the old method. But by the years, anesthesiology has become a very big science. Now this is the ovarian carcinoma. This is the uterus. This is ovarian carcinoma. Now, in those days, what happened? We used to do exploratory laparotomy. You have no imaging, no ultrasound, no CT. In that condition, we used to, by clinical diagnosis and vaginal examination, we used to go, even our senior teachers used to operate on the hydrosalpinx. The single Mullerian duct, it gives a single cavity. These are the previous pictures, the abnormalities of the uterus I told you. Is that I shown you the pictures of diagrams, previous slides. Now see the two Mullerian ducts, the two ovaries. Actually, they came to me, that lady was not conceiving. Now, we had to explore, open the abdomen and saw these features. The uterus from a single Mullerian duct. See, this is a single Mullerian duct which conceived a child, and we did a cesarean. I did a cesarean section. Actually, I opened my gloves and took the photograph, and asked my one sister there to hold it. And actually, I didn't want to lose any time, so she had no gloves. So you go back to Sushrut's operation theatre. So in case of emergency, don't look for sterilization, achekina and all that. You have to save that life. Okay.